Hey everybody, it's Ashley, physical therapist with TravelTrim, and I am here with Dr. Forrest Allen. Dr. Allen is a osteopathic doctor, a DO, with a dual fellowship. He's dual fellowship trained with double board certification. Is that right?
Mm-hmm.
I said it right? In interventional pain management and sports medicine.
Yep, correct.
And Dr. Allen practices at the Houston Clinic in Middle Tennessee, a number of locations.
Yes.
Lebanon, Nashville, Hendersonville. Okay,
Yep.
Lots of locations. And we're here to talk a bit about pain. So I have some questions, and but before we go there, I would love for you to introduce yourself just a little bit more, your education, your background,
Sure.
how you wound up treating pain.
Sure. So I started medical school back in 2008, graduated from med school, then did a did a residency actually first, kind of like a general practice residency in Chicago. And then after that, I did a fellowship in sports medicine because I really like to treat athletes and kind of like the musculoskeletal stuff. And then after that, I wanted to do something where I could do more procedurals, and I kind of like the procedural aspect of it.
When you say procedures, what does that mean?
So, well, that's kind of what interventional pain management is.
Okay.
It's different kinds of procedures that aren't necessarily surgical, but they're typically more past the conservative side of things.
Okay.
So we do a lot of different procedures. That's probably what I spend about half my time doing, is just procedures at the surgery center.
Okay.
Yeah.
So it doesn't necessarily mean scalpel.
No. So it ranges quite a bit. So the majority of what I do is just inject. It's like percutaneously. It's through the skin. It's not through a big incision. It's injections, epidurals, nerve blocks. We do radiofrequency ablations where we kind of get rid of nerves in a minimally invasive way. We do spinal cord stimulators. There's anywhere from 5 to 10 other procedures that a interventionalist could or would do, and they're not surgical necessarily, but it's a little more invasive than your conservative care.
Okay, I was just making sure.
Yeah, which is a lot of people don't understand or know what that even is, and
Right.
it's a newer field, and it's actually growing every year. So part of my job is just to educate people on what I do.
Wonderful, and I actually have a question about that, but before we delve into that, let's differentiate. Like when people say pain, like I hurt, there are lots of different categories of that, and for the sake of treatment, we categorize as chronic and acute pain.
Yeah.
So what's the difference between acute pain and chronic pain?
So depends on who you're asking, and if you go by a book, I guess 3 months is about how you differentiate between acute versus chronic pain, and they'll subdivide it further into acute, subacute, and chronic pain, and that's anywhere from when it started to 6 weeks to 3 months, and then all past 3 months. But in general, anything that's lasted beyond 3 months is chronic pain, you could consider.
And then acute pain, that's from a tissue injury of some kind.
Typically, but
Okay.
that could be chronic. That could be lifelong, for some people. So it's not really the mechanism of injury. They differentiate based off time.
Okay, how long you experienced it.
Most people, yeah, exactly.
Okay. And then for the sake of this conversation, we'll stick to chronic pain.
Yeah.
Pain, people that have had pain for more than 3 months.
Yeah.
And what percentage of the population would you say, let's go just the United States, have like some sort of pain that's lasted longer than 3 months, chronic pain?
Yeah. I mean, I don't know the exact percentage, but I would estimate there are tens of millions of people that suffer with chronic pain every single day, particularly when you get past your 50s and 60s. When you get older and you have arthritis and it's just hard to get around, I mean, most people are suffering from some kind of chronic pain in one way or another. So it's a high percentage, I'm sure.
And then there's intensity to the pain.
Yeah.
And we know based on studies that people process pain differently, and there's cultural implications to saying that there's pain involved. So for this conversation, we can stick to good old USA.
Okay.
Let's talk about our culture, Western culture, and how we handle pain. I would love to know what's like you said, interventional pain treatment was a newer,
Yeah.
what's it called? Field?
Yeah.
Newer study. How is that different than what someone hears pain management? How is interventional pain management different?
So pain management traditionally is, I think, thought of as medication management. And a lot of pain management providers who do procedures also do med management. They can be pretty heavy into the med management, and that's fine. Some people need medications, obviously. The interventional side of it, though, is, like I said, growing pretty rapidly. And so every year there's newer procedures that come out that are less and less invasive, that are becoming more efficacious and just more beneficial for patients. So that's kind of how I separate it. The pain side is just chronic med management versus the interventional side, which is more procedural.
And with the chronic med management, is that still narcotics driven?
Yeah, primarily, yeah. And it's obviously with the whole opioid epidemic, that has turned things upside down for doctors, patients, the whole field.
Right.
Okay, so we have to be very aware of all that stuff.
Right.
Because obviously there was a major problem. There's still a major problem.
Mm-hmm.
It's getting better. But yes, it is traditionally still managed with opioids for the most part, because that's the biggest class of medications to really treat chronic, moderate to severe pain.
Got it. And I would love to have another conversation with you about that
Sure.
at a different time.
Sure.
As a physical therapist, we also treat pain, so it's amazing to have these conversations with somebody that treats it without pushing opioids and narcotics.
Yeah.
All right, so why is treating pain so challenging?
It's a very good question. So I think what makes it so hard is that there is no test for pain. There's no test for pain. It is completely subjective. We have MRIs, we have CT scans, we have nerve conduction tests, our physical exam, our history, all that. It doesn't actually say where the pain is coming from, unless it's just totally obvious, like someone broke their arm.
Right.
Okay, that's obvious. But especially with back pain or neck pain, there are so many things in the spine that can cause pain, so it just makes it very hard to drill down to exactly what's causing it. So most of the time when someone comes in the office, their source of pain is not that obvious, believe it or not. And that's a very common misconception. People think that, this should be very black and white. We should be able to say exactly what's causing it, and we should be able to fix it, which is understandable, but it's just not how it works, particularly with spine problems.
And going off of that, we know that someone that is not experiencing any pain at all could have an MRI that shows degenerative disc disease and bulged discs and pinched nerves, but they are not experiencing pain.
Exactly.
Conversely, some people could come in complaining of debilitating pain, but nothing on the MRI would warrant the pain. Now, there's been a lot of research, I guess in the last 2 decades, about how the brain processes the painful stimuli. Is that another reason, because pain is processed in the brain and you can't see tissue injury even with a CT scan of the brain?
Right. You're absolutely right. Pain is completely processed in your brain through nerves.
Right.
And so everyone processes pain differently. So everyone's pain threshold is different. And there's a big psychological aspect to pain. And depression, anxiety, stress, things like that play a huge role in how you process pain. So yeah, it's a big part of it.
And those things can actually trigger musculoskeletal pain.
Yeah, I would say so. Yeah.
Which is another reason why it's complicated to actually treat pain.
Yes.
Why, if it is processed in the brain, why can't we just ignore it?
Well, you could try. People, there's all kinds of therapies that, mindfulness therapies, meditation kind of things, where to get a person to learn to live with their pain better, to cope with it better. But it's tough. Pain is there to show us something's wrong.
Right.
That's what it's meant for, really. So it's hard to ignore it.
Got it. Have you found benefit from any of those mindfulness therapies
Yeah.
at all?
Absolutely. I mean, I think people with chronic pain, I think there's a huge proportion that have anxiety and depression chronically, and they go hand in hand. So if some of those patients, or a good portion of those patients, would do things like practice meditation, any kind of mindfulness therapy, things to get anxiety and depression under control a little better, other than just medications. If they did that, it would change the face of chronic pain, 100%.
That's interesting.
Yeah, absolutely.
And like you said, there are emotional and psychological effects to being in pain.
No, totally.
And then the people are fearful of hurting, so then they back off from their activities even more.
Right.
And obviously exercise is another one of those components that helps the emotional and the psychological side of things.
Yeah.
So it's a vicious cycle, which is why what you do is so important. And so I would love to expound a little bit more, delving into more of the psychological side of pain. And in your practice, in your studies, what other things have been factors in terms of why we hurt the way that we hurt? Like, what other factors can people realize are being tied into their pain?
You mean other than the
injury? Like, we know that there's been an injury, there's damage to the tissue, but that doesn't necessarily always account for experiencing pain. So what other things could we potentially tease out that could help with the recovery process?
Well, like I said, the emotional aspect of pain is very complicated, and people's psyche plays a huge role in chronic pain. So it's really those two things. It's the physical and the emotional, or the psychological aspect of it. And those two things together is what really has the biggest effect on pain, whether it's chronic or not. So as...
There's a bird trying to get in here. He's very interested in our conversation.
By far. So like, if, as doctors and physical therapists and medical providers, we try to treat the body, pretty much, and there are psychologists and therapists that take it from a more of an emotional or psychological aspect. But, if you could mesh those things together, and if patients not only saw their doctor, but they saw a therapist or they saw a counselor or something, the people with chronic pain, I mean, that would change everything. It really would.
That's amazing. And do you think that, often we hear, especially after a spine condition or surgery, that it's been repaired, I shouldn't be hurting anymore, but I'm still hurting. Are those the kind of people that you see?
Oh, yeah.
It's been fixed, but they still hurt.
Yes. Oh, I see that all the time. I probably get most of my referrals from surgeons.
Okay.
And maybe the patient hasn't had surgery, or maybe they have had surgery. But yes, that happens all the time, where the problem was fixed with surgery and they're still hurting.
And so you would recommend getting more help on the psychological side of things.
Any of that would be useful.
Yeah. But what can you do to help people?
Well, so it depends on the person, depends on their symptoms, of course, but...
How about your most common procedures? What do you do most?
I do a lot of like epidurals and nerve blocks, things like that. So basically we're putting some medicine into an area that is perceived to be painful, or we think it's painful. We're putting some medicine in there to see if we can calm down pain and inflammation. That's the most common thing I do by far.
And is it lasting forever? Like, if people get relief, does it last?
That's probably the most common question I get. How long is this gonna last? And the truth is, you never know, because everyone is different. Everyone is different based off their age, what's wrong with their back or their neck, what they do for a living, what kind of activity they do at home, how much they exercise, things like that. So it's very hard to predict someone's response to these. But in general, patients can have relief that lasts anywhere from a few months to, I think people pain relief lasts for 5 years,
Mm-hmm.
or longer, or maybe just goes away completely.
Right.
But it's very hard to predict someone's outcome, to be honest.
Got it. And are there any common factors that you've seen that are associated with really good positive outcomes and conversely really negative outcomes?
Yes. So people that do the best are going to be motivated, number one. They are going to be active and they exercise. And when I say exercise, whether that's walking or lifting weights or things like that, to stretching and core strengthening, stuff like that. Those are things people just don't want to do because it's work and they just don't want to do it.
Right.
And so the people that are motivated to do those things and to take care of themselves, those are the people that do the best by far. And then on the other side of it, the people that don't do well typically are overweight. They're not motivated. They live a pretty sedentary lifestyle. They maybe don't eat very well or do a lot in their free time to better themselves physically.
Mm-hmm.
Whether that's exercising or
what about smoking?
Smoking that never helps anything. So smokers do worse by far, especially with back problems.
Okay.
Yeah. If you're a smoker and you have back pain, just stop.
Right.
That's one of the best things you can do. 100%.
And there are a lot of surgeons that won't do anything
Right.
if you continue to smoke.
Absolutely.
And so, with the more sedentary lifestyle, those that are less motivated to get out, get active, what advice would you have for them in terms of starting out on a change of lifestyle? And I know that you're not a nutritionist. This is not necessarily your forte, but if it's associated with good outcomes for a procedure that you might do for them.
First thing they could do?
Yeah, what can they do? Somebody's listening that's hurting, that wants to not hurt anymore.
So if has chronic pain and they can't exercise, if they can exercise and lose weight, that's the best thing. And losing weight is diet related more than anything.
Right.
Right? So exercise helps, of course, but it is so much diet related. So your diet is something you can control.
Right.
Whether you're in pain or not, you can decide whether to eat less or eat more. So that would be the first thing I would focus on, which is not, I was going to say one of the easier things, but it's not. It's actually very hard. But if they could take that approach and kind of limit calories and watch what they eat healthier, and maybe help bring some of the weight down, that would help with the pain.
Mm-hmm.
So that's probably the first thing I would do, but it's easier said than done.
Right. So tell me a little bit about more of the spinal nerve blocks that you're able to do. Why does that work?
Yeah.
Tell me a little bit about that.
So there are theories on why it works or how it works. So basically, like I said earlier, you're putting in medicine into a certain area that is painful or inflamed.
What kind of medicine?
It usually consists of a steroid and some numbing medicine like Marcaine or lidocaine. Sometimes we put saline in there. One theory is that you're putting steroid in, so it's going to decrease pain and inflammation because the steroid is an anti-inflammatory.
Right.
Another theory is that when you put a bunch of volume into an area that has a lot of inflammation, you're kind of washing away these inflammatory mediators. So that's another theory. It works because steroids can just take down pain and inflammation.
Right.
Basically. It doesn't work for everyone, but to fix pain, you either treat it from the outside with therapy, whether that's chiropractic, massage therapy, physical therapy, whatever. You fix it by getting medicine to the problem, through an injection or something like that, or you fix it anatomically with surgery. You correct the anatomy. The only other way is through medications, taking something orally.
Right.
So the way we do it with the epidurals and nerve blocks is basically just getting medicine to the spot that we think is the problem.
And what about the nerve stimulators or spinal cord stimulators? What is that about?
So stimulators have been around for decades, and the idea is basically you are so let me back up a little bit.
Okay.
So all pain is perceived in the brain through nerves, right?
Right.
So if you're going to calm that pain down and not have to have surgery, you basically have to attack the nerves, basically, if therapy's not going to work, okay?
Right.
So that means you either have to block the nerves, ablate them, freeze them, overstimulate them, somewhere or another you're kind of getting to the nerves. And that's what spinal cord stimulation or peripheral nerve stimulation is. You're basically overstimulating nerves so they stop sending pain signals to your brain. It kind of tricks your brain into not feeling the pain that was constantly there.
Now that's similar to like a TENS unit.
Yeah, people think of it that way. And it kind of feels like a TENS unit for some people.
Okay.
So yeah, that's not a bad way to think about it.
Okay. And it kind of distracts your brain from thinking about the pain?
Well, again, there's different theories.
Okay.
There's different theories on how it works. No one knows exactly how stimulation works, which is crazy, but
right?
It's been around for decades. But
since the 60s and 70s.
Yeah, something like that. But pain is very misunderstood. It's very poorly understood, and so it's not surprising that we don't know exactly how these things work. But we know it works. It can work very well. So we do them, and people tend to do very well with them.
That's awesome. What advice would you give someone that knows probably a family member that has suffered from chronic pain, debilitating pain, maybe even on disability because of pain? What advice could you give someone so that they would have a less chance of developing? Like, is chronic pain, is it hereditary?
Is it hereditary? I think having a bad back, for example, there's genetics to that, for sure. I don't know if it's hereditary or not. That's hard for me to say. There's certain risk factors that are hereditary. Your weight might be hereditary. Having degenerative disc disease, more so than someone else, is hereditary to an extent. Having chronic pain, I think, is a lot of it is lifestyle. It really is. It's if you get in a car accident, you can't help that. That's not your fault. But if you're someone like most of the people that come to the office that just has a bad back or has bad neck pain, some of that can be fixed with diet, exercise, physical therapy, lifestyle choices like not smoking, things like that. So if you're doing those things, that's about the best any of us can do, really.
Awesome. How important are healthy relationships? Like someone, if they don't want to do therapy, how about just somebody to talk to?
Yeah, it all goes back to like the psychological and emotional aspect of pain. So I think it's extremely important that people have a good emotional support system. They have good relationships with their family and friends, and it just, like I said, it's all goes back to the whole emotional aspect of pain. Because if you're feeling depressed, alone, sad all the time, your pain is going to be worse, 100%. So having those relationships and having healthy relationships with other people, talking to a therapist, whatever, that's extremely beneficial.
So when should someone come see you?
Usually if the conservative care hasn't worked, so if they've done physical therapy, whether they've tried the chiropractor or massage therapy, it doesn't matter to me. I tell people, if there's something conservative that you would like to try that might work for your pain, do it. So if those things work, or if the pain is too severe to do those things, then they would come see me. And also if they're looking to avoid surgery, that's a big one. So I see a lot of people in the office because they don't want to have surgery. They're looking for a less invasive option. And like I said, there's new things that come out every year. So it's not just the nerve blocks and ablations and stimulators. There's newer procedures every single year that are coming out that are done through incisions like that big. And so that's kind of where things are trending toward. No one wants big surgery, right? So that's part of what the field is kind of bridging that gap between, surgery and then the conservative care. We have this big gap here, and we're trying to shorten the gap.
Would it be beneficial for someone to come see you while they're doing PT, or should they have failed PT first?
No, they can see me first. And a lot of times they see me before they try therapy. And honestly, the people that do the best, if they're in a lot of pain, try the nerve blocks, stuff like that, and do therapy. So if someone comes to me for an epidural, something like that, I try to get them to do therapy with it, because those two things together tend to have a better outcome.
He's a smart man right here. So, just let's talk some of your favorite advice in terms of taking care of your spine. Let's try to avoid any pain, lessen chance of degenerative changes, those types of things. Obviously, we have genetics. We can't change how our bones were built.
Right.
However, what are your favorite pieces of advice to somebody that wants to take best care of themselves, avoid injury or whatever?
So staying active, not being sedentary. Two great things that I recommend to people is trying yoga, Pilates, and you don't have to go to formal physical therapy, but if they will, that's great. I encourage it. If they've already done it, then maybe I'll say something like yoga or water aerobics or something where they're stretching out their back muscles, their neck muscles, something that maintains their core strength or increases their core strength, because most people have no core strength.
Right.
So something like that. And then of course the weight loss thing is huge, but it's a tough conversation to have with patients.
It is, but necessary if they want better outcomes.
Right, but a lot of them, they know that. They know they're overweight. They know they need to lose weight.
Right.
So you just got to have that conversation in a careful way. But yeah, it's always good to encourage them to lose weight, I think.
Would you just review with our viewers, when you say stay active, that doesn't just mean you walk from your car to your desk, even if it's through a parking garage. What do you mean by staying active?
It depends on the person, I think. Okay, so if they're 90 years old, obviously they can't do what a 20-year-old or a 30-year-old can do, but I would say at least 3 to 4 times a week minimum, doing some kind of aerobic activity for 20 to 30 minutes if that's possible. And again, it's going to depend on the person.
And aerobic just means your heart rate is above rest.
Something that gets your heart rate up.
Right.
And whether that's a treadmill or a bike or something in the water, that's great. Again, stretching, yoga kind of stuff is great, which no one does, but that would probably eliminate a lot of back problems. So things like that. It's tough for people to exercise 3 or 4 days a week. I know I don't, but I need to. But I think it would eliminate so many problems, especially with the back and the neck in particular.
Got it.
Yeah.
Well, thank you so much for your time. I definitely want to revisit some of these conversations. Pain is one of my favorite topics because I enjoy helping people not be in pain. But if you guys need Dr. Allen, you can find him at the Houston Clinic.
Yep.
And he also does a phenomenal job on his social media platforms. He does some real good educational things. You can follow him on Instagram and Facebook, right?
Yeah, Dr. Allen Pain Doc.
Dr. Allen Pain Doc.
And there's a lot of pictures and videos on what it is we do. So that's always useful to actually see these things instead of just kind of hearing about it or reading about it.
Absolutely.
Yeah.
Well, thank you so much for your time. I appreciate it.
You bet.
Thank you, guys. Thank you.